everybody. Thank you to join this session. I'm very happy today because, when we were preparing this intervention, we were, what would be the topic today? And we need to talk about cure and how we help cancer and cancer cure. And Hicham told me, no, we need to talk about prevention and how we avoid people to be sick. And he said, when we brainstormed that, we said, no, it's the same technology. So the idea today is to say that as Dell, we are building solutions and we are building the infrastructure to help, of course, both cure and prevention. And it's important that technology with AI, with compute, with a large amount of data help to reach this goal. And I want to let the pitch to Fabrice and let Fabrice explain what do we mean in terms of prevention.
Thank you very much, and thanks to the organization committee for its invitation. So we'll see what role can have the digital twins in prevention and oncology. So digital twins are virtual representation of health condition, and they allow representation of individuals' physiological process, such as aging or cancer process. Aging is the main cause of chronic disease, and the World Health Organization classified aging as a disease in 2015. Aging is beginning at 27. And as you can see on the figure, the risk of the main chronic disease is strongly increasing since 54 years. And the risk of avoidable diseases can be strongly reduced by prevention. That is 40% for cancer, 52% for cardiovascular disease, and 75% for type 2 diabetes. It's also important to note that the potential longevity gained by prevention alone is up to 24 years at 50 years old. Another paradigm in prevention is the relationship between organ aging gap and mortality. This is the gap between chronological age and biological age of organ. Aging of organ is not linear and not homogeneous along time. And if one organ is aging faster, this is associated with a 20% increase in mortality and also a strong increase of cancer risk. But fortunately, the reversibility is very high by therapeutic and prevention interventions. And now, we also have ability to quantify all system and organs aging and also to extract relevant anomalies for personalization of anti-aging therapy. And all this data will be integrated in digital twin. So this is up to 600 parameters that we use to assess patient organ aging and risk of avoidable diseases such as cancer. And of course, thanks to AI, we can extract relevant patient analysis and calculate, this is new, the global and organ-specific aging. So this is a new era of neurosciences by the quantification of all biological system aging and also by the new therapies that are emerging with relevant effect to slow aging and reduce chronic disease risks such as cancer. So how we can assess the aging situation of a patient, which data are needed for a digital twin? First one are full body composition analysis and also full body imaging. And these data are associated with new polyomic clocks that are strongly emerging, such as epigenetic clocks that allow assessment of aging pace of cells, proteomic clocks that provide aging gap of organs and system. This is a difference between biological age and chronological age. And both clocks can also help to early assess results of anti-aging and preventive therapies. These data are incorporated in digital twins and also behavioral and clinical data, of course, functional abilities that are measured by the physician, biological systems assessment, and of course, actionable genomic and pharmacogenomics. When you have all this data, you can build a digital twins, and we designed it in Astrium Institut, which help us to quantify the years lost without care for each anomaly we found. Also, it helped us to test virtually anti-aging therapy, and it helped also us to measure evidence-based longevity benefits of each intervention. This is very important to increase the motivation of patients to follow the rules to improve their survival. Also, these tools can also help early quantification of benefit, that is within 2 months after initiation of prevention therapy. And we can also use this tool to perform cohort analysis that help us to report a potential benefit gain of 9 years, average 9 years longevity by prevention practice. Of course, all detected anomalies should be recoverable. We can also use digital twin to improve follow-up of patients in a preventive intent, that is remote monitoring of patient-reported outcomes. And it also helps us, as you will see, to follow therapeutic effects of preventive measure. PROMS, patient-reported outcomes with remote monitoring, is now a standard in oncology for patients undergoing therapy because it reduces by 50% the risk of mortality in patients undergoing chemotherapy or therapy, anti-cancer therapy. And of course, these tools are workable in longevity and prevention area because they help to assess the improvement of quality of life, symptoms, to measure physical performances along time by therapy and, if needed, early alerts of side effects. So, as a conclusion, new therapies and lifestyle changes can improve longevity from 10 to 24 years and highly reduce chronic disease risks such as cancer. And digital twins associated with artificial intelligence are extremely relevant in anti-aging and prevention domains because they help to quantify organ aging gap, disease risk, and potential longevity gains if the patient apply what is recommended. And it also helps to personalize therapy and early assess therapeutic benefits in the same manner that it's used in oncology for patients with cancer. Thank you for your attention for this.
So what we mean here is, thanks to technology, you have more data, more compute power that allows you to reach this level of performance to collect data and treat that and have these results?
We already had the data. The digital twin help us to modelize and to virtually see all functioning system, all biological system and organ aging and risk associated with increased aging of some organs. We already had the data, but AI and digital twins help us to extract relevant data because without this tool, for one patient, you have this is 1 hour or 2 hours, you have to see all results in order to extract the relevant data and calculate manually the potential longevity gain. With this tool, of course, it's more automatic and more rapid, but the physician must absolutely control all results because, as usual, you can have some hallucination, you can have some strong results. Even if you provide the journal, the articles based on them, you are based to calculate this. So the data we have it, but the technology helps us to extract the data and modelize effect of therapy too.
Okay, so yeah, more compute power helps to leverage the performance, and I think, Marc, that's exactly what you are facing where you are fighting cancer. It's exactly more. Merci. Again, yeah, it's more data, more compute, more everything because when all the prevention and all the result that the patient, even if he lost weight and do everything he needs to do, finally there is some people who get cancer and have to be treated. So when it got to be treated, how the technology helps you today?
So at Gustave Roussy, so we are a comprehensive cancer center. So we are fully dedicated to cancer, and actually The way we work now, it's more about changing the paradigm that say we define a cancer based on the tissue of origin of the cancer. We are more now convinced that we have to define a cancer based on the tissue, biological, cellular, and molecular characteristic of the tumor of the patient, for each patient. And for this, we do a lot of tests that generate a lot of data because we do genomics on the biopsy of the tumor. We do blood, urine, and stool tests, MRI, CT images, whole slide histologies. Now we have technologies that permit us to have the tumor environment. So not only even which kind of cells are in contact with the tumors, and all these technologies generate a lot of data, and we have to find a way to integrate all this information for the clinician to have all the cards needed to make the best clinical decision for the patient. And actually, the term digital twin is not very, for me, it's not a precise enough term, because if we ask people what is a digital twin for him, you will have several definitions. Some will tell you that the digital twin it's a mathematical modeling of the cancer behavior. Some, like us, will more talk about a patient twin, because at the end, as we collect all this information about the patient, his tumor, and this environment, we can after look for in the data warehouse what are the previous patients that were biologically the closest to the new patients that I have in front of me. And this is kind of a knowledge, a big knowledge base, because at the end, when you are a patient, you come, some oncologists you will be taken in charge by an oncologist. But if you have a rare cancer, maybe the last that the oncologist that follow you is not the one that I have seen another patient that had the same characteristic, maybe 6-10 years ago, and so by looking at which treatment was successful and unsuccessful on this very close biologically patient, we can save time for the patients, and in cancer, save time is adding more chance to cure the patient.
So if I understand, for both cases, for prevention and care, you are looking for the future. You are modeling the situation today, and you are able to project for the future how the cancer will be or how the patient will be. That's correct?
Yeah. The future can be a very close future as try to know which treatment will be the successful one for the patient. But it can be too the fact that this information can after be used for prevention, because you at the end you know that a patient that has a cancer, this type of cancer, has this biology when he arrives, and this treatment, this mutation was, for example, genetic mutation was found in this patient. Maybe you can add this on the layer of tests you can do on the preventive side in order to know, okay, this patient has more chance to develop this type of cancer than someone random in the population.
So it's not a one-way direction. You're between prevention and care. Care can also feed prevention. Yeah. That's exactly how we are working today.
Yeah.
It's also important to note that cancer is a specific disease because the host, the patient, modulates the growth of tumor. Cancer is not an independent tumor alone inside a host. The host, the patient, the normal tissue modulates growth of tumor. That's why it's very important in the primary prevention as well as in the secondary prevention to reinforce the host. And all technique that reinforce the host, that is physical activity, that is specific food and some drugs, may have the same result, that is redux of that is metastasis or appearance of another tumor. So reinforcing the host is the same way, the common way between before and during cancer situation.
Just to make some precision on what I said before about the fact of changing the way of thinking the cancer, it's because actually we have seen that sometimes we do not deliver a treatment because it was created for example, a lung cancer with an ALK mutation, let's say. So normally you have to give this treatment only for these patients. But if you find another patient that has a cancer elsewhere than lung, that has this same mutation that is targeted by this drug, why do not use this drug on the patient? Because it probably will work. That's why for us the tissue is not something that has to be so strong as factor, even because the majority of the patients that come at Gustave Roussy are metastatic patients, are patients that actually tested several treatments before, standard of care, that didn't work. So at the end, when they come with several tumors on different tissue, the tissue of origin, it's only one of the variables that we have to think about in order to choose the treatment, but do not ask to be the only one. And all the tests we do, for example, here in the figure I put it, why we do stool tests, because actually we have seen that just looking at the microbiota of the patient, we can know if some treatment will work or not. And we really think that we have to really have a global view of the patient and his tumor, because one tumor of one lung tumor is not the same that the lung tumor of another patient. So we have to really took the characteristic that are specific to the tumor of this patient in order to decide for the best treatment, or maybe to include the patient in some clinical trial, or to test new drugs and that sort of thing.
Okay, so an overview of the patient, taking more data to have an holistic view of the patient, that helps, of course, to understand how cancer will grow and evolve inside the body. Same for prevention, because having more data helps you to have a better understanding of the situation and also project on the future. So the same technology at the end for both cure and prevention.
For prevention, we use the same technology such as imaging. For example, in the primary prevention, we use CT scan or full body imaging to find a little tumor that will be curative. And of course, we also use full scan imaging when patient has been treated for a cancer in order to find a relapse and so on. In a biological point of view, such as genomic point of view, we also use actionable genomics in order to find one or other genes that is associated with high level of cancer or high level of relapse. So yes, this is the same approach, but prevention, secondary prevention, aim to reduce, to find little tumor that will be treated by surgery or radiosurgery and avoid appearance of metastasis. But yes, we use the same, this is the same word. The difference in when patient has cancer is the cancer, because we also have to take into account the data of biological tumor and microenvironment, and we must associate both data from host, the patient, and tumor characteristic to find the best treatment that will destroy the maximum of tumor cells, but also reduce the strong impact on patients' normal tissue. And these new tools will help for that, because we now also have targeted therapy against cancer that are strongly specific of tumor cells and is relatively have relatively low effect on the normal tissue. So yes, this is the same philosophy, of course.
And if I can add, prevention in cancer is not only before the cancer, because you have the cancer, you have the treatment, and you want to avoid to have some relapse of the disease. So the fact to collect, for example, the specific mutation of the tumor of the patient when he was sick. We have the treatment, there is no more cancer, but regularly we check in the blood if there are if we can detect this specific mutation of the tumor that is still circulating, there is a risk of relapse or a risk of metastasis that can be created. So we have to act before that the metastasis come. Because we collected this information at the beginning when the patient was sick, we can do prevention of the fact that he can develop metastasis or even relapse after the treatment.
And the average, it's 72% of relapse?
It really depends on the cancer type.
And I think that the reason why investing in more prevention, promote that with the council that you are building, Hicham, is the way to serve those platforms and help to improve the culture of that.
Yes. Good afternoon, everyone. First of all, thank you for having me with you today. It's really an honor to speak after Fabrice and Marc. Yes, after the really two fascinating presentations we just had, my key takeaway is that preventive and curative medicine do have different use and even different definition of the digital twin. And yet it is the same technological object, which requires the same technological foundations and capabilities. It requires the ability to collect, structure, harmonize, and process the data for one single patient, data coming from different sources. Preventive medicine is clearly the next medical revolution. I'm speaking under your control, Professor Denis, for the next decade. And it will benefit from the technological foundations we are currently building for curative medicine. However, in the race for AI adoption in Europe, we still have one critical gap to bridge. It is the reliance we have on the use of LLMs which are trained on non-European datasets. And this is a big risk. To ensure trust, relevance, sovereignty, speed, attractiveness, whatever, call it whatever you want, we need urgently to build capabilities to train these LLMs on territory-based healthcare data. And this will require the same multi-cloud technologies. I'm going to please you, my friend, because this is exactly what you are doing at Dell, going from the on-premise infrastructure to sovereign cloud to public cloud. And we need to build really reliable regulatory compliance training environment to help us bridge this gap and accelerate on both medicine, curative medicine and preventive medicine, which use, once again, the same technological foundations as we just heard. And to continue this reflection, we, together with AI for Health, together with Dell, we co-organized a scientific conference on prevention and longevity medicine, which will take place on February the 5th at Maison de la Chimie. It is just a short walk from here, from this wonderful place. And we invite you all to continue this reflection with us. And please, save the date, mark your calendar, and join us. Thank you.